Two. Okay. All right. So Mary Jo and Lori, you all are representing the Washington area Village Exchange. I've always known it as WAVE, so I have to read what the acronym stands for. Tell us a little bit about WAVE and what it does, Mary Jo.
Thank you very much, Steve. I really appreciate this. So I'm Mary Jo Deering, and I'm the president of the Washington Area Villages Exchange, or WAVE. WAVE is an umbrella organization of aging-in-place villages in Maryland, Virginia, and the district. Villages are volunteer-driven organizations of neighbors getting to know and help neighbors, as we like to say. There are 74 villages in our wider region. If you'd like to know more about villages or see if there's one in your area, please visit our website at Wave Villages, altogether, wavevillages.org, and I'll be putting that into the chat. We're really happy to be co-sponsoring this program. I think it's a very important topic. We thank Steve Gurney and his pro-aging community for hosting the session, and Lori for setting it up. And thanks especially to Dr. Kogan for sharing his time and insights with us. Happy to be joining you, and looking forward to the presentation.
Excellent. All right. So Lori, you're next on deck, and I believe you're going to be introducing Dr. Kogan. And what I'm going to do is drop behind the curtain and let this go. I'm really excited about today's discussion. All right, should be able to unmute there. There.
Good morning. I would like very much to welcome everyone. It's wonderful to be here, and I hope that you all will enjoy this presentation as much as I plan to. Dr. Kogan and I share a few things, a common Slavic heritage, the fact that English is our second language, but perhaps most importantly, we both share an inspiration from our grandmothers to be in, he ended up in geriatrics, obviously, and now in integrative medicine, and I volunteer in the aging field. But we were both inspired by our grandmothers, and I think a recent conversation brought that up, and I think that's just really kind of a remarkable thing, and makes me feel very, very pleased and touched to be able to introduce, and it is very definitely a privilege on my part to introduce Dr. Kogan and to invite you to enter into his world and to get a peek into his perspective on what the future could really be for older adults. So with that, welcome, Dr. Kogan. Misha, as we call him.
Thank you, Lori. Yeah, Misha is better.
That's right, I know.
I'm trying to, I think that's part of the messaging that I think the doctoring, quote unquote, is getting a bad rep, and we have to move into less hierarchical structures. So before I put the slides on, I'm going to say just a couple of words about myself, but through the presentation, you'll see some of my philosophy, some of my personal sharing as well. Just exactly what Lori said, I end up in doing this because I think I didn't spend enough time with my grandma. She was a healer. It's my mom's mom. And I never knew this until a lot later, actually, but I remember some of her presence and some of her energies. And she passed when I was very young. I was, I think, 4. But that imprint was so powerful that I always missed. And I think I'm still compensating by loving older adults and doing whatever I can to make their life better. So with that, I'm going to put the slides on. And we'll jump right in. So I'm an associate professor of medicine at GW and also medical director of Center for Integrative Medicine. I started a nonprofit called AIM Health Institute some years ago. And through my career, I've been sort of evolving and developing tools, not just on how to keep people healthy, but also how to look at aging through a very different lens. And I hope that by the end of this talk, you'll start realizing how little aging and health has to do with medicine and how much it has to do with the way you live your life and what are the power in changing things that you can do, even when sometimes it feels like those changes don't make sense, but actually after some time, some cumulative process, you're realizing that you can do a lot more than anybody ever told you. So with that, and if I look up to the right, it means that my second screen is on the right. That's when I'm looking at the chat and at the question box. So just FYI. A couple of disclosures. I co-own the practice where I see patients in addition to seeing patients in the university. And I draw loyalties from this books, and also early next year, the Optimal Aging textbook is, oh, it's not a textbook, it's just a book coming out, which is kind of general public translation of integrative geriatric medicine. And this would be a lot better book, I think, for all of you tuning in today, because the integrative geriatric medicine is a textbook and it's very dense and it's almost 800 pages and it's too expensive to my liking. So this is what the quote that I want to start with. Successful aging is far beyond healthy and vibrant. It is rectifying internal conflicts, paradoxes, and redefining life's meaning and adding years to life and life to years both. The last phrase, of course, you've heard before. I kind of added it to my own making of the first sentence or first part of the sentence. So let's start with some terms because it's actually very important. Otherwise, I think it's hard to understand some of the context here. So anti-aging is what I want to separate from what I do. Anti-aging is a kind of a real clinical work. It's very not clear whether there is a true science behind anti-aging. The whole concept whether we can reverse the aging is actually, believe it or not, controversial. There are a lot of experts, clinicians, and researchers claiming that aging is a reversible process. We'll talk about this in upcoming slides. But that's not what I do. I do like certain parts of anti-aging. I practice some of them, but I don't call what I do an anti-aging. I call what I do is geriatrics or integrative geriatrics, or just healthy aging. So of course, geriatrics is a medical subspecialty of taking care of people who are over 65 by definition, or just people who are aging. Gerontology is a science of aging. Believe it or not, there is juvenology, which is a science of how you stay young. That is for me, the least of my interest, but I honor those who continue to practice or believe that this science brings some benefits. It probably does to a limited degree. Longevity science, it's very real and rapidly growing, and we'll spend at least 5 minutes probably on discussing some of the aspects of it, as well as what is it based on. I'll show you an actual proponent of immortality science. I'm not kidding, it's a real thing. And then, of course, the age-wise approach, which is sort of my making, and I'll kind of walk you through what that means. So is aging a disease? So this is a very famous professor, highly decorated, one of the leaders of gerontology. And this is not a trick question. This is the real question that a number of advanced experts in academia are asking. Believe it or not, there are now several countries in the world, including Australia, for example, where they claim that aging is a disease. They have a ICD-10 code for it, and the providers can bill for it. So if somebody just coming in and they want to talk about their aging, the provider can bill the insurance for it, at least in Australia, as an example. And you'll actually will see in a second why in Australia particularly. So, I'm not going to actually discuss this. I think this is more philosophical point at this time in our time, rather than a true question. I've argued with a lot of my colleagues that I disagree with this. I don't think aging is a disease. I think it's a natural process. But the intervention into the process of aging at certain places may actually make a lot of sense. And as we go through the presentation, I think it's going to click in several places why thinking of aging in certain moments as a disease could be very important and very helpful for improvement of longevity and aging. So I promise you I'll talk about immortality. So those of you who are not familiar with this is Aubrey de Grey. He's kind of a big time celebrity. Pretty much everyone in Silicon Valley know who he is. There are millions and millions, if not billions of dollars going to some of his work, because he's the first person who said in an upcoming several decades, we will sort of unlock the process of aging, and we will be able to completely arrest it and thus being immortal. And there are people who believe him. I mean, it's not, it's a concept that for him is not a crazy idea. It's an actual process toward which they're working now. The organizational consents. I don't think that and he's an extremely smart man, by the way. He may be slightly out there from the way he looks at the world, but that doesn't make him crazy. And frankly, in certain ways, he actually brings a tremendous progress to the world, because he's put the question up there. And now there's a whole cohort, and not just biohackers. The biohackers is the person who decides on themselves to test the idea of all kinds of experiments personally to try to be healthy and live longer. But he put it out there, and now there's a lot of researchers, serious researchers, you'll see one in the next slide, who are basically saying, okay, well, immortality may be too far gone, but what about goal of 150 years? Is it realistic? And so here comes David Sinclair, and if you have not heard this name, and if you have not read this book, I highly recommend it, with a disclaimer that when it comes to some of the supplements in there, hold your horses, but the theory behind what David wrote is very profound. And he's the first person who not just randomly said, look, in our lifetime, within about 20 years, we will start seeing a significant proportion of population living above 100 and actually over 120. And the reason he's stating this is because of some of the molecular discoveries. So for example, the gene SIRT1 or sirtuin is basically the gene that if you modify it successfully in animals, in every single animal model, you prolong life by a minimum 20%, and in some cases up to 50, with average of about 30. And we already have tools today that basically will say, okay, if I give an animal this exact resveratrol, caloric restriction with intermittent fasting, NAD boosters, and then hold and heat exposure, I'm going to expand an animal life by 30%. Now, has this been done in humans? No, of course not, because obviously that's going to take a lot longer to prove. But the principles apply. And so even if some of this intervention is going to fail, the chances are that eventually all of this will start succeeding in a combination or in a package or in, as I like to say, integrative approach is extremely high. And this is not the only molecule. There's many others. These are the big two ones, IGF-1 and mTOR. And I don't want to spend a lot of time on this because that's really not the point. I'm not trying to give you a medical talk highlighting some of this. This is just as examples. So why do we age? Believe it or not, there's still a massive argument going around. I will show you what I believe is probably correct, and it's a summary of multiple different things. I'm not going to go through this in detail. I do want to show you that the social functional isolation and disengagement is probably most important from immediate impact, as well as two others. So the chronic inflammation and the neuroendocrine. The free radical theory is very questionable. There's a lot of problems with it. The mitochondrial deterioration is obvious, but the tools of arresting deterioration of mitochondria are just beginning to be. In contrast, for example, social engagement is not a rocket science. And even if our culture doesn't believe in this, and nursing homes is sort of a common scenario, that doesn't necessarily mean that that's the right way of doing business. And the true theory that seems to encompass a lot of others, and currently probably one of the most important one, and it is the David Sinclair's brainchild, basically saying, look, the main reason we age is the fact that our systems that keep us in check begin to fail as we age. And yes, it's a genetic principle, but it's a lot more complex than that. So the example is, let's say you have a gene that's responsible for killing the cell that becomes cancerous. And so eventually, if that checkpoint of doing that fails, you're going to get a cancer. And that's the whole process. And if you look at the variety of diseases that are generally associated with aging, cancers, heart disease, neurodegenerative diseases like Alzheimer's, basically, this model fits perfect, because in that model, you start having not just one failed switch, but many. As you'll see in an Alzheimer's, because I will talk about Alzheimer's and the current progress in the care of Alzheimer's, and you'll understand that they're not just one switch, but 50, if not 100. And yes, we do have a capacity to look at that, but if we stop looking at this as a medical problem, and you'll understand again why. But, you know, how we age for us on our individual level obviously comes with how do we see aging. I mean, this is when our students and trainees come to us and we take them to work at nursing home, this is what they see. You know, if you go to places like Blue Zones, which we'll cover in great detail, this is how the aging looks there. This is a 100-plus-year-old farmer who still works 10 hours a day on the farm. And those of you who get interested in this, on my YouTube channel, I recently interviewed a US farmer who's 95, who looks just like that, works 8 to 10 hours in the field every day, and doesn't plan on slowing down at all. So you can see this exceptional stories and learn from them for yourself. And the information is actually out there. And so the rest of the talk, you'll see, I'll be in general ways positioning the whole of this set of pieces of information so that you can learn them and you can start incorporating them in your life. Then there's exceptional stories. So this is Olga. She was born in Canada. She passed now recently, but she never exercised a day in her life. Very difficult upbringing. Raised kids on her own. In the mid-70s, kids, grandkids out of the house, somebody took her to the track and field and said, you know, let's start exercising. So she started exercising. And by the age around 90, she became one of the most decorated elite athletes of all times, with more medals and records than some of the most famous athletes you've ever hear about. Yes, this is exception. She never exercised, but she completely transformed her physical capacity to do things like run 100 meters, you know, or jump, like in this picture. And if you're interested in her story, the book is called What Makes Olga Run. And if you want, at some point I'll type it. And we have our own stories, right? We have our own people in our lives who are our inspiration. This is my father. This is about 5 or 6 years ago, Philadelphia Marathon. He just turned 80 here on this picture, and he finished in top 3 at about 6 hours. So this is an 80-year-old man who's ran 26 miles in 6 hours without slowing down or stopping. And, you know, that to our common thought process, it's unusual, but it shouldn't be. My point, well, I'm not trying to say everybody should run a marathon, but it shouldn't be an unusual for us to realize that you can do things like this at this advanced age. So, but let's look at things a little different now, because this is what can be, but this is what we have today. We are last in developed world on every health measure, pretty much, except the cost. Our life expectancy is now not increasing, but decreasing. If you compared us to, say, Japan or Korea, we are almost 5 years living shorter on average. And, you know, it's, you need to ask questions why. We hear a lot of stories as to opioid epidemic. We hear a lot of stories that there is, you know, obesity epidemic. We hear a lot of different things here and there. But if you look at this from perspectives of pure numbers, if you pause for a second and you say, okay, well, opioids kill this amount of people, obesity probably has this impact, but you start wondering what is actually happening on a much grander scheme of things, because, okay, it's easy to say obesity is responsible for everything, but that's not actually true. Neither is a particular opioid, you know, any particular trauma, opioid epidemic, or any of those things. They're all of them together, but it's much more than that. And if you look at how we age in this country. We age horribly. We're sick. By the time we reach at age of 65, we're 3 times more likely to have multiple chronic conditions compared to France. Just think of this for a second, 3 times. They have 15% of having 3+ conditions, and we have 42. It's almost threefold. And we have only 20% chance of having just one condition, while they have 1.5 times more. So, everybody should pause and say, okay, it cannot all be obesity for obvious reasons, because we don't have 3 times more obese people. It's a lot less than that. So it's a lot more complicated. But then the reality goes like this. How do you think we manage all of this complexity? Do we think everybody go to a nutritionist and an exercise expert? Of course not. This is what happens. By the time people reach age of 60, on average, most people take, as you see, 5 or more medications. So 36% of people over 60 take 5 or more medications, okay? And it's not unusual in our world as geriatricians, or even if you're just an internist and seeing a lot of older adults, you're gonna see people coming to you taking 15, 20 medications. And the problem with that is very, very simple. It's this. Every year, that complexity becomes a 3rd common cause of death. Basically, we kill somewhere between 200 to 300,000 people when there are adverse reactions to correctly prescribed medications. This is not a mistake. This is a business as usual, because we don't have any other alternatives. Because when people go with a regular cold to see their doctor, they get Tylenol. And nobody thinks about this, but Tylenol kills about 1,000 people a year. Or, you have a self-resolving condition, everybody gets overexcited, you start ordering tests. There's a fallout because then you find something irrelevant on a test and you have to follow with another test, or then you have to get a biopsy, and then there is a complication during the biopsy, a bleed or something, and there you have it. So it turns out that the way we do business is so medicalized for pretty much everything. And if you get one thing out of this talk, learn how to not use healthcare system when you don't need it. And it's not so obvious, actually, believe it or not, but it is an essential point. And there's a great question, and I'm answering it now. What would you recommend consulting a geriatric pharmacist, impact of multiple medications? Before you consult geriatric pharmacist, you should say, very simple, what can I get off of? And the answer is you probably can get off of nearly half of all the medications almost all the time. The issue is just who's going to help you. And that's the problem. The problem is we don't have enough trained physicians or providers who understand how to do business else differently. How can you, instead of taking acid suppressant, you can manage acid reflux in 20 different ways. If you have high cholesterol, you don't have to take high cholesterol pills. You have probably 20 to 30 different ways of dropping cholesterol. Presumably you don't have other risk factors to which you have to take statins. So, and we can do better just from general perspective. Right now, today and yesterday, there's a major conference on the Hill that's Biden administration put together saying, look, how can we end hunger in this country? Well, some of this is obvious. It's only 2% of the agriculture bill currently goes to sponsoring healthy eating. 2%, 2. The rest goes to sponsoring a large crops, sponsoring, parts of industry that have nothing to do with health. That basically a business for business kind of thing, just so the money gets turning around. And then nationally, none of this is covered. Exercise is not covered. Nutrition is not covered. Health coaching is not covered. Mind-body medicine is not covered by Medicare. In order for Medicare to cover nutrition, you have to have kidney failure, diabetes, not pre-diabetes, diabetes, and there may be 1 or 2 other conditions. So by the time, and if you don't have a kidney failure, it's like before kidney failure, you can't get it, because this is the medical system says, well, you have to wait until your kidney fails before you're going to start changing your nutrition. I mean, it's like, if you think about the way the system was designed, it was designed so long ago when none of this, in essence, was relevant, where we were not asking questions because our population on average was not getting close to 80 years of age. And that is the problem. The problem is we moved on, but we have not stopped thinking medically in the way we were thinking 50 years ago. And that has to change. So, and the way to change it, this is my concept. I'm not saying this is the only way to go, but I do think that this is an important principle. I do think that non-medical intervention and staying healthy are critical, underutilized. And this gives us a framework. It's one of several frameworks I'm going to show you today. So the integrative geriatrics is a new field of medicine that advocates for whole person, patient-centered, primarily non-pharmacological approach to medical care of elderly. The practice of integrative geriatrics is rooted in lifestyle interventions such as nutrition, movement therapy, mind, body, and spiritual approaches that allow patients to have different paths to their healthcare. One that utilizes pharmaceuticals and invasive procedures only, and this is the most important, only when safer integrative approaches are not available or not effective. Unfortunately, 90% of work I do right now is in reverse. The patients come to me because everything else fails. They go to their doctor, they have problems, they put on medications, and they still have problems. And then they come to me, and often they come to me late. I saw a 89-year-old gentleman yesterday with the list of problems so long and the list of medications so long that all of the appointment we spent is, and the parents are like, what about the better diet? And what about taking some supplements and doing this and doing that? And I say, look, we can do all that and we will. But unfortunately, we're in a situation where his health is so deteriorated that I don't know what we can bring back. If I were to see him 10 years ago, or if the system would give him the tool that I can give him now, 10 years ago, his life probably would have been dramatically different in this past 10 years. And I'm not the only person saying that, look, medicine has nothing to do with keeping us healthy. It's responsible for actually less than 20% of actual overall outcomes of what's going to happen to us. Yes, it takes care of all of our acute problems. Yes, there are certain chronic conditions where medicine is critical, like some acute but chronic inflammatory states, infectious processes, which could be longer lasting. So those require a lot, or interventions like replacement of joints. I mean, those are obviously medical, but if you think about this, actually 80% of what's going to determine how long we're going to live and how healthy we're going to be in the last 20% of our life has nothing to do with medicine. It's really the social personal determinants of health. It's an environment. It's individual genetical factors, it's behavior and lifestyle that go on top of all those things and the choices we make day after day. I love putting it in this context. So the tree, in order to stay healthy, has to have a good nutrition, excellent roots. And if the tree starts having some of the branches go bad, you know, your leaves falling off and it looks diseased, any good botanist is not going to simply say, oh, let's cut those branches and that's it, right? They're going to also try to treat the whole tree. They're going to try to figure out what goes in keeping to this tree this vibrant and healthy. And the same with us. We have to address all of these pieces. For example, if you don't sleep very well and you have hypertension and diabetes and you go into your doctor and you never actually talk about sleep, or you talk about sleep and then they just give you an Ambien, which sort of helps, but not actually, and actually in some ways makes it worse. And it's not FDA approved for chronic insomnia. You didn't really address what could literally contribute to improvement of everything I mentioned, including diabetes, including hypertension. Those are the conditions that sleep can improve if the sleep gets a lot better. So, but we have to go back and we have to start with things that we can do ourselves, right? So is it all about lifestyle? That question always comes up. And this is a funny picture, right? So you can talk about this topic of lifestyle in a variety of different ways. But when you talk about aging, probably the best way to put context of lifestyle is in the context of blue zones. So what are the blue zones? The blue zones are particular communities in the world, and I'll show you the map in a second, where elements of lifestyle and outlook and just engagement in society led to superb quality and length of life. And it's the areas that produce the highest concentrations of people over 100, and we use the word centenarians for them. And the person who started this work with the NIH grant is Dan Budner. And the Blue Zones concept is still going very strong. The book is pretty old by now with multiple new editions. And it's still a bestseller, and it's been a bestseller for many decades for a good reason. So the original blue zones that have been described are the blue zones in these areas: Loma Linda in our backyard in California, Costa Rica, Nicoya, Sardinia, Ikaria, and then Okinawa, Japan. There are some other newer blue zones that have been added in the past several decades. I don't think it's relevant for this presentation, but if anybody interested, there are more detailed stories now that are available. And what's common about those blue zones is that nobody exercises, they just move. I'll show you how they do that. We're going to actually talk about example of blue zone in a second. They tend to automatically balance stress and activity. If you are a shepherd in Sardinia and you walk for 5 hours because your ship needs to be moving to get enough food, when you get home, you're going to follow the natural cycle of things around you, the sun, the animals, and you're just going to sleep a lot longer than, for example, we would in our society, right? Surprisingly, when you look at the diet, there are only a handful of true consistent principles. So one principle is the diet has to be very high in micronutrients, so very dense in micronutrients, and specifically in phytonutrients, and low in glycemic index. What does it mean? It doesn't mean that the carbs are low, but the types of carbs that people are consuming seem to be very low in glycemic index. So when they turn into sugar into bloodstream, it takes a lot longer. And so these people don't get peaks of sugar like this. They're just a lot more gradually rising and falling. Some cultures are vegetarian, so some societies like Loma Linda. Some eat a lot of animal protein. For example, Icarians tend to eat dairy every day, and they tend to have some meat almost every day. But the second critical principle, everybody has some kind of intermittent fasting and some caloric restriction as a normal part of living. Why? It just happened that way. I'm sure they didn't sit there and say, oh, right, 200 years ago, we're gonna need to do intermittent fasting because Dr. Kogan said so. No, this just happened. If you're shepherd and you get out of the house at 5 or 6 a.m., you can only take a small amount of food with you because you're walking all day, and you do have to take water, and the weight is limited, and right? And this is not a culture where machinery was readily available. So they grew up with this system in place where they figured out just naturally over centuries how to do it. Food as medicine, I'll show you an amazing example. And this is the concept that we as a society completely, unfortunately, lost. And this is, if anything you bring in your own blue zone at home, it has to be this, because this is a huge, and it's not so easy to do, not so difficult to do. And then developing the sense of belonging. All these societies tend to have a very communal way of living. And again, I'll show you that. I love to add this element. This also checks who's sleeping and who's not. I'll give you 5 seconds to look at the slide. I joke with our fellows in geriatrics that to be a good geriatrician, you have to have 3 things. You have to don't care how much money you make, because this is the only fellowship that makes less money if you take the fellowship. So if you don't take the geriatric fellowship, you make more money. So from financial perspective, it doesn't make any sense. You have to have no sense of smell, important, and you have to have a great sense of humor. So if you have those 3 things, you're a successful geriatrician. I think that's one of our specialty jokes. So the question is, can we set up our own blue zones? Let me show you how I've learned about some of this and how some of my thought process evolved. Years ago, I read this article by Dan Budner in New York Times. And, this was, it struck me. I was reading the article, and one thing struck me. So this gentleman who is Stamatis Maraitis, who's in this article, he gives this story about what happened on this little island. And the story was so vivid that I said, okay, I gotta go. And, it's a tiny island, just actually very close to the Turkey. It's a lot further from Greece. It is a Greek island, and it was originally used to send prisoners over there as a sort of, you know, a naturally occurring jail, because it's one big rock. There's a lot of herbs and sort of natural plants, but it's very hard to cultivate because you see what it looks like. And there's no real fields to sort of make it into agriculture or anything. There's a good amount of water, a good amount of sun. And of course, this is the Mediterranean Sea right there. So gorgeous views. And, you know, you walk out of each garden and everybody grow their own food, 100% pretty much. Everybody know how to use plants. So this is I think this was a lavender and a couple other herbs that they would do. They just routinely know what to do. This is, I think, I think this was some kind of a nuts that they were explaining how they put them into the food on a very frequent basis. And imagine you get up every morning and this is what you see, like just this proximity to the to this natural state of being in elements and being basically living with the view that in America, people will pay millions of dollars just to have a view like this. But this is how you wake up every day. Food grows naturally everywhere. So you don't have to wait. You don't have to go to the store to buy things. It's a lot fresher. You know, it's often, they just walk literally 2 steps out of their house to get the breakfast. We don't really usually see this in our culture. So this was critical for me as a part of the reason why I went to Korea, that I knew that there's a most important honey. Everybody hear about Manuka, but Manuka pales to compare to the heather honey, which is actually supposed to be the most important honey for medicinal purposes. I'm a beekeeper. I have my own bees. I don't have a heather honey because it's very difficult to actually cultivate the heather, but there it's naturally grows, very high in protein, excellent source of, just like you get a regular cold, you get some kind of infection, and that heather honey, believe it or not, is going to probably shorten the length of pretty much any self-resolving cold or self-resolving infection. And so what happens is they have this tool, it's very low cost, it's always available to them, and they would not go to the pharmacy. They would go to a pharmacy when things escalate, but not for self-resolving things. So, right, so this would not cause the iatrogenic Tylenol toxicity or some other toxicity for seemingly benign medications, which unfortunately they're often not. They have really surprisingly healthy relationship with alcohol. Okay, me and my friends did not have very healthy relationship during that trip, I'll tell you. But they drink usually a couple glasses of wine. And again, some cultures drink, some blue zones, Loma Linda does not, but some do. So small amount of alcohol seems to be okay, most likely. And you know, the work is very simple, and there's a lot of self-reliance and productivity into 80s and 90s. So this was, I spent a whole day with him. So this gentleman is a beekeeper, and you can see actually boxes of frames here. And I was just following him in the field. He mostly does heather honey and then some other honey. And he's 85, he was lifting, each box that is full of honey is about 50 pounds. He was lifting 2 boxes at the same time. And he said, oh, I just recently slowed down. I only lift 2 now. I used to lift 3. And, you know, you hear stories like this and you're like, oh my, right? But that for him, it's just a normal, he doesn't think about it. He's starting to slow down because, you know, he likes certain food. He probably eats a little too much. You can see it here, but, you know, he's completely vibrant. He's physically completely active. He's sharp, and he's in mid 80s. So that should be the norm. Now, we're probably not all of us gonna go out there and raise bees or be farmers, but we can create our own engagement that gives us health too. I'll give you a super simple engagement that I do a lot. We have wood stoves in both of in our main house and in our cabin. And I chop all my wood. I cut it, even I live in Tacoma Park. So people know me, they would often call me and say, hey, we got a tree down, come, take it. And I bring it, I load it in the car, I drive it, I chop it, I move all the pieces, even if they're 100, 150 pounds. And to me, that gives me a meaning because it also saves on electricity bill. And I feel like I'm doing great exercise. And also actually it is a sustainable way to hit my house. And so with that, when I was evolving through all this blue zones and thinking, I come up with this 13 principles, what I now call an age-wise approach. I don't think I'm going to spend a lot of time on each, but I want to give you a little quick sense of what they are. In summary, they basically mostly lifestyle-based, but then there are also application of certain medical ways of thinking, and also the way that my work over the past 15 years led me to believe that some of those pieces are more important and practical and not extremely expensive. So the breathing, learn to breathe right. It's a lot more sophisticated than you think. If you have not seen this book by James Nestor, Breath, you have to get it and you have to read it. Why? Because you're most likely going to identify that about half of the population does not breathe right, and not taking enough pauses in a day to practice deep breathing, which is the most fundamental and most important impact on cardiovascular system. Eat mostly plants and intermittently, self-explanatory. Spend time daily away from a thermal comfort zone. So what does it mean? Make sure you're comfortable in both extreme colds and extreme heat. Why? Because in the long run, it teaches the body to not just be tolerant, but it engages certain metabolic machinery that turns on genes of longevity. And if you're interested more about this, definitely Lifespan book is great by David Sinclair. The body is born to move. This is my rule 32, daily 30 minutes exercise with at least 2 hours of some kind of movement. That includes taking trash. That includes going in a parking from your car to the mall, whatever it is, but roughly 2 hours of movement. I track all my activities with this little thing. It's called Aura Ring. It's always on my finger, but you don't have to. You can just approximate the total amount of movement. So detox, I'm not going to talk about this in great detail. It's a bit more sophisticated topic. If anybody ever know what Ayurvedic medicine is, you know very well what I'm talking about. Optimizing micronutrient and knowing your specific needs. That's not everybody, not physicians will be a hard time often telling you this. Why? Because certain things are not well understood within the context of disease, but it's much better understood within context of preventing disease, and physicians are not necessarily always the best people to do so. Food as medicine, I already spoke about this. Don't use the Tylenol and Motrin if you have a little illness. If your fever is low and if it's going to pass, take arnica for minor sprains. Take the heather honey, or if you have manuka, perfectly fine. Take manuka honey for regular cold, or vitamin C. Even though the evidence for all of this is probably non-existent, but you're not going to take things and get your body used to chemical intervention that gradually may start shifting the balance, or can give you acute problem. Like Motrin can have stomach ulcers, even from just few doses. Find your life meaning and keep refinding it. So often meaning changes as we move from workforce to retirement, but still important to stay with that. Don't be afraid of looking into your dark places in your soul. Spiritual involvement often is one of the most important things for longevity, because you find new directions, you find new goals in life there. Activity, balance, and rest rhythm, it's your balance, not necessarily somebody else. That takes some coaching to get there, right? But if you do and you're feeling well, keep that balance. Community, put your mind, heart, and soul to some kind of effective use. It doesn't have to be a direct outcome. It doesn't matter. Follow your dreams, even if they don't necessarily lead to some profound outcome. That's actually secondary, believe it or not. That journey is way more important. And then form your healthcare team. And this is critical. I said healthcare, I didn't say medical care. So of course you're gonna have a primary care doctor. You can't be without it, but you need other people. You need coaches, you need nutritionists, some kind of a movement expert. Now that could be one person and all. If that's the case, that's wonderful. But it doesn't have to be. So it depends on resources. Certain things you can find at no cost at all, like your friends and your church, and learn what they're good at. So I'm gonna move us to this last part. I think I'm going to try to finish. I may skip a couple of slides in the cases just so that I can answer more questions, okay? So here's an example of a program that addresses Alzheimer's disease. And I want to show you this, not necessarily that the data is very clear or to be scientific here, but I'm going to show you what's possible, just so that you can get a sense what the future of a particular chronic illness is going to hold. So you all probably heard about this. So a couple of years ago, this new drug for Alzheimer's was approved. It's called Adalimumab. Unfortunately, the drug is exceedingly expensive. The drug itself is $56,000, but then you have to spend over $30,000 a year on imaging and visits to physicians. The drug causes 8% brain bleed, and it's extremely unclear it does any benefit whatsoever to any patients with Alzheimer's. When FDA approved it, several people on an FDA approval panel walked out of FDA and said they're never going back, because they said the approval was a scam. It should never have happened. And this happened mostly because for about 30 years or so, not a little less, 20 plus, there hasn't been any progress in the effective treatment of Alzheimer's. So finally, there was a drug that may be doing something and was immediately approved. And, you know, it's controversial and it probably doesn't work. There's a lot of back and forth about it. And, you know, the shocking point here with this is we all know who's in this field that doing one treatment for this condition is going to always fail because it's a multifactorial illness. And we also know, look at the timing of this article, 1999. This is more than 20 years ago. This was published in Journal American Geriatric Society. If you look at some parts of the world, like Okinawa, they have twofold less chances of getting Alzheimer's at any age, wherever you look. It's, well, this age, there was a kind of a glitch here. But if you look at age of 85 to 90, 30% in Japan and US, and only about 12%, so it's more than twofold. And, you know, it's obvious the lifestyle. It's pretty straightforward. The genetics between these populations in Japan and Okinawa are the same. And actually, the most common genetic risk factor called ApoE4 is the same between Americans and Japanese. So it's all lifestyle. And we knew this. More importantly, everybody knows this. This is the commissioner of FDA who said, look, we cannot treat chronic conditions with a single intervention. Everything has to be multimodal. So even the medical society waking up to realizing, look, we can't just give one pill for every ill. It doesn't work when you look at the complexity of chronic illness, because underlying metabolic pathways are much, much more complicated. So here comes Dale Bredesen's, those are his books, if you guys are interested. And Dale is a researcher in Alzheimer's who started noticing that through his research, there are so many triggers that end up at the end leading to Alzheimer's. He started putting them in categories. And it turned into this kind of basically multiple different types of Alzheimer's. Some of them are hormonal. So if the certain hormones are lost, people are more likely to evolve to have Alzheimer's. If people have vascular problems, you know, if they have high sugar, if they have inflammation, if they have toxins, or if they have trauma. When you go to see a neurologist, no one will ever look at this in this complexity. You'll get a medication and maybe the thyroid will be checked and be told, but that's about it. And that's probably less than 1% of what we do now. The actual treatment plan looks something like this. I'm not going to go into it. It's very complicated. This is just an example. But the bottom line, in parallel, we'll look at every possible underlying driver. You may say, oh, this is crazy. Yeah, I agree. It is complicated. But let me show you what it looks like when you actually successfully implement this. This is 2018, 3 patients in this paper from our clinic. This is the first 100 patients when Alzheimer's was reversed, and patients are still reversed. So they no longer have, by definition, Alzheimer's because they improved from diagnosis to normality. So this is 2021. This is the first clinical trial by Bredesen's group where the 84% of patients with early Alzheimer's from non-controlled 24 patients have improved on this protocol. Very high proportion of these patients had ApoE4. It was a short follow-up. Now, this is the data from 250 patients from total number of patients on RECODE program across the country. There are a lot more now. So about 50% improved, 23% not changing. And this is data from our clinic. At this point, we're basically getting close to, we're over 50 patients. This needs to be updated a little bit. And the reality is we are seeing approximately 67% of patients are improving or not progressing. Our population is much older than on average. And I'll show you two cases real brief. I think I went through this very quick, so we're gonna finish right on time as I planned. So this is one woman who was referred to me for mercury poisoning with a rapid cognitive decline. Her neurologist was telling the family that the patient has 2 or 3 years left by the rate of progression. So this was probably 5 or 6 years ago. So we quickly identified that mercury was not the only problem. She had multiple other issues. She had a high sugar. She had mold toxicity. Her hormones were not great. She had elevated homocysteine. We addressed all these drivers. We also addressed her diet, which was very high in simple carbohydrates. 6 months into program, she had improvement from 19 to 24. Now, 5 years later, she's maintained at this level. And obviously she didn't die 2 years ago, and she's not going to die in 2 years. So here's a much older person at 83. This is a case that was just a couple of weeks ago. This was probably one of the fastest improvement, but I'm not exactly clear yet. I don't have enough complete data as to why that happened. But so she presented with basically a kind of a midway into the decline, so a lot more advanced than mild Alzheimer's. And she is moving not a lot because of severe arthritis in hips and knees and not planning on doing knee replacements. She doesn't want them. A lot of carbohydrate craving, really doesn't like any spicy food. So we did a lot of immediate coaching. We put physical therapy in her home. They're coming to her. A couple of basic supplements like B vitamins and fatty acids. And in 10 weeks, she improved from 16 to 23. Most likely because she was willing to stick with a ketogenic diet. It seemed to have a dramatic impact. It usually doesn't happen that profound, but in this case, it happened. So with that, the takeaways that a lot of older adults are over-medicated and experiencing iatrogenic complications. I hope that everybody who's listening, trying to at least think about their own regimen and see if anything can be simplified. Lifestyle matters, and probably matters more as we age, not less. And it's probably the most important quality of life and longevity predictor as to how you live your life and what can you do to optimize those medical problems you have. And healthy aging must start with healthy lifestyle. And age-wise is by no definition the only approach. It's just one approach. There are a lot of people in this field of healthy aging who you can follow to gradually improve your health and your lifestyle. And we're entering the times where diseases, complex chronic diseases, will be managed with a complex data, often computer-assisted protocols that are highly personalized. This whole term of personalized medicine is coming. And with that, we'll go to questions. And we have about 4 or 5 minutes to do the questions. I see there's a lot of different questions. So maybe what I'll do is I'll start with Q&A box and we'll go from there. Is Alexander technique good for breathing? It's great for breathing. It's great for posture. Posture is very important. It's a great thing if you find a good provider. Time outdoors, absolutely. Remember that Icarian slide? They live their life outdoors. They're only indoors for sleep. That's it. They even eat outside. Most of them have porches and verandas. We probably can't have that, but it's a big deal. So I'm not going to talk about this here. Visit my YouTube channel. I have a whole talk on CBG for an hour, what we use it for. Delta-8 should never be used by anybody. It's 100% toxic. All of the Delta-8 is currently on the market is contaminated with heavy metal and pesticides. I have several presentations on that. My YouTube channel also covers the Delta-9 as well. I do accept new patients, and just to go over this, so I do accept Medicare. I don't accept new patients for primary care and Medicare, but I do accept consultations through the university. But in my private practice at the moment, we're out of pocket. We're considering shifting that to some kind of a copay structure. But because the amount of time this work requires, and Medicare tends to not pay for time at all, only for complexity of care and medical care, and they don't pay for health and prevention. So that's part of the difficulty. I don't know about downloading the PowerPoint, but the whole presentation I'll put on my YouTube channel if anybody's interested. And I believe that Steve's going to do the same. So it'll be available at the Wave website. Steve, correct me if I'm wrong on this. I'm not sure. Yes.
Absolutely. Yeah, we'll download that today.
Great. And yes, so both my practices accept telemedicine. In my private practice, I take every state, but I'm not sure about the GW. I think takes only the tri-state area for the telehealth, but you should check with the central office at GW. Okay, and then there's more questions in the chat, right? Let's see what I missed. The name of the book in the chat. I think I said what makes Olga run. So I love that book. So this is about her story, how she grew up and her difficulties and how she became this elite decorator. And by the way, when you read her story, it's fascinating because her diet is horrible. The only good part about diet is oatmeal, but she ate very little vegetables, tons of meat and all kinds of, and yes, she changed her diet some later in life, but only around the age of 75 when she started training and she started realizing the diet wasn't consistent with the amount of activity she was doing. So, all right, I think the other books, I have them here. So those are my books. And then once you get the actual slides, you can scroll through them and you will see the Breath book that I really like, Lifespan book, which is the David Sinclair's book. I think there may be some other books that I mentioned but missed. I can't think of right now. All right, well, okay, so I think there are a couple more. There's another question. What is your recommendation of getting sunlight without sunscreen? Yeah, that's not an easy question. I often disagree here with dermatologists. I think that if you can get 30 minutes at least of sunlight before 10 a.m., probably very safe. I think the whole idea that somehow we have to put sunscreen no matter what time we get outside is a little overcomplicated. Unfortunately, sunscreen is also a controversial topic because some of them do contain toxins. And so even natural sunscreens like zinc, for example, is not necessarily all that 100% safe. So it's not an easy topic. I think that when you're at any significant prolonged sun exposure, you definitely have to use sunscreen, or you just shade your body partially. And parts of your body, like hands, for example, tend to have a lot less skin cancer. So, if you have a t-shirt, for example, but you're protecting your face continuously, that also is an option. So if you don't want to use the sunscreen, which I understand could have some people cringe. Okay, so there are a couple other questions. So are patients with all Alzheimer's, or do some have other types of mental deterioration causes? It's a hard question. We particularly concentrating right now just on Alzheimer's disease. You kind of have to start somewhere. Other types of dementia are a little more difficult to treat, I would say, but Alzheimer's, especially patients who have ApoE4, there is data now, and it's a very solid, very high quality data to say that if you implement a lifestyle and you have an ApoE4 and you implement the correct lifestyle change at around 40s or 50, not only you're not going to get Alzheimer's, your risk of Alzheimer's is lower than if you have ApoE3 than an average population. That has to do with the fact that ApoE4 has some protective mechanism. It's a pro-inflammatory gene. But if you put anti-inflammatory lifestyle and you control those acute inflammatory responses, you actually, at the end of the day, look better on average than somebody who doesn't have that genetic makeup. That is something that's been discovered in the last 2 years, I would say. So I would definitely completely say that people who say, oh, don't test ApoE4 if you have history of Alzheimer's disease, that is the worst thing you can do. You have to test yourself as soon as you can, preferably in 40s, because the treatment would be you're going to change your lifestyle. You're going to try to screen yourself for inflammation, for cholesterol early on. And those are the things that when you put the right lifestyle interventions, you're not going to need medication. And even if you do need a medication, it actually could be quite helpful on top of the lifestyle. So very important point. I just basically answered the next question. You have to get some genetic testing. You have to go see providers who specialize in lifestyle optimization for prevention of Alzheimer's. I think that's really important. You probably, if you're not, if you don't have the symptoms yet, the sooner you start, the better, because by the time Alzheimer's evolves and you have symptoms, it's much harder to treat. So I think we're a couple of minutes over. So maybe what we should do is let me just finish every question that's here and we'll just stop at that. Are there all, this is, thanks Lauren, a great question. Are all 13 principles equal? No, they're not. It's going to be individual. For some person, exercise is going to be maybe more important. For somebody else, their diet may be relatively poor and they have to work on that. So no, so it's highly individualized. I think the point that it's like this. Think of your list of problems as the holes in your roof ceiling. When the rain comes, if you patch up, all but one big hole, you're still gonna have a water going in. That's the whole point. You do have to do the best you can. We probably don't know every hole anyway, but once you start implementing this complexity, and yes, it's gonna take time in your life to do all this, and yet you're gonna have to prioritize this. But I think what you can get out of it, because it's not just living longer, it's feeling a lot better. And I'm just gonna leave it at that. So Linda's asking medical question. I think I'm going to skip it just because the answer is very sophisticated, and I don't think that it depends on an individual moment per person. Coffee, coffee is perfectly fine in the small amounts. Actually, there's been a study published 2 or 3 days ago saying that people who consume 2 drinks of coffee live significantly longer. And that was much better controlled study than some of the older ones. And also coffee decreases risk of Alzheimer's and Parkinson's, both. So small amounts of coffee seem to be very beneficial. It's very high in antioxidants, and the caffeine itself in the small amounts is actually probably also has some benefits. So I think with that, I'm gonna say thank you, everybody. I know I probably didn't answer a couple of questions, but they seem to be coming. And thank you so much, Steve, Mary Jo, Lori, for inviting me. And I hope this was helpful for everybody.
Yeah, it was fantastic, Dr. Kogan, and great. Again, the audience had some great questions there for you as well. So just a reminder, everybody, this is recorded and it'll be on Dr. Kogan's site, on our site, and on the Wave site. And really, thank you a lot for opening our eyes to this, the future of medicine for older adults.
Thank you, everybody.
All right,
Thank you,
everyone.
Misha.
Okay. See you soon.